Hello, my name is Nick Holliday, and I am the host of Talking Trisomy, a podcast brought to you by Soft, where we support families and help change the narrative for all things trisomy. Today's episode, we really wanted to talk to a handful of our medical professionals because it is Trisomy Awareness Month. So this particular episode was really unique. I got with my co-host, Dr. John Carey, and we invited 4 other members of our medical committee to join with us. We got a handful of questions that were submitted by families, and so we were able to answer those questions. And well, before the episode began, I asked our members or the panel, I said, go a little deeper, share a little more. And so they do just that. They got onto a pretty good dialogue conversation where they were asking questions of each other, which was pretty cool. So I want to thank Dr. Kosiv, Dr. Hamill, Dr. Green, and Dr. McCaffrey for taking the time. You'll notice Dr. Green was in surgical garb, and he actually had to leave right before the episode ended. So we just were so grateful for the attention and the care that these particular doctors have for our trisomy 13 and trisomy 18 kids. Some of the questions were specific to trisomy 18, but really they're not. They were able to answer them, and they relate to both conditions. So we're just so grateful that this particular episode, we were able to talk all things trisomy 13, trisomy 18, and we thank the panel for their time. If you like this episode, please share it, please comment, do all those things. We want to support more families. We want to help continue to change the narrative. And so we hope you enjoy this episode. Hello, this is another Soft production. This is under our podcast, Talking Trisomy, but today we've got an exciting kind of change of pace. We are coming to you together with a panel of our medical professionals that make up Soft's medical committee. And so we're excited. We'll have a little introduction here in a minute, but this particular panel, we're going to discuss trisomy 18 questions that both families have submitted, as well as just topics that might just come up. So we're excited. Thank you so much, this medical panel, for taking time out of your day to join with us. And this is all part of Trisomy Awareness Month in 2026. So hopefully we'll have some cool information that has come about here in recent months and years. And so again, Dr. John Carey is my co-host. John, welcome, and maybe you can go around and introduce everybody, and then let's start with the first question. But thank you, everybody, and those of you listening, we hope that you have a good time.
So thanks, Nick, and it's a pleasure and honor to be here again. To my knowledge, we've done this every year since 2021. It's always been in celebration of Trisomy Awareness Month. Ordinarily, we've done this on Trisomy 18 Day, but because it turns out that a number of us are going to be away on Trisomy 18 Day, we chose to do this as a recording. But it's a pleasure for me to have our special guests, most of whom I think will be familiar to this audience, at least on my screen. Dr. James Hamill, just below me, who's a cardiac surgeon, well known to the trisomy world because of his work with surgery and acceptance of many children when he was in Nebraska. I then see Dr. Marty McCaffrey, University of North Carolina, pediatrician and neonatologist, a longtime associate of mine. And then I can see Katya Kosiv, a pediatrician, cardiologist, pediatric cardiologist at Yale University, and also very much involved in the trisomy community, author of an important paper in pediatrics when she was a fellow in training on heart surgery, one of those change the narrative type of articles. And then Glenn Green, like everybody else on this call, has also been involved in changing the narrative as an ENT doc, more formally otolaryngologist, and who has really championed this idea of airway evaluations in the infant early in life, and now with important published work. So added those extra color for all of you, and it's great that you're here. So we have 4 questions that have come, and I'll mention the first name of, in each case, the mother. I won't mention the last name or any identifier in case that this won't be okay, but I'll mention the person, the name of the child too, if it was in the question. And we thank all of the parents who did submit the questions, because they do bring up a number of other issues. So in the time we have, we might address some of the let's say, issues that spin off of the original discussion. So Mary sent a query. Rose is 8 years old. Her heart was repaired by Dr. Hamill when she flew from California to Omaha, Nebraska for repair of her double outlet right ventricle and tetralogy of Fallot. She's actually doing well. Her cardiologist shared that her pulmonary valve may need intervention at some point. That may be at 13 or so. A few people have mentioned to me this can now be done in the cath lab. Can you briefly let me know if the cath lab would be an option? Her initial repair was full open heart surgery. So Jim, perhaps first, and then maybe Katya could add if you could address that question of pulmonary valve obstruction being cared for in the cath lab.
First, I was delighted to read this question and to know that this particular child, who I remember, and her mom, of course, very well. I'm particularly happy to hear that she's still alive and kicking and actually gets the opportunity to worry about having a pulmonary valve replacement someday. It's a great question too, because the combination of double outlet right ventricle with underdevelopment, small size of the pulmonary valve is actually pretty common, if not, well, it's not the most common in the patients that I saw, but it's a very common combination. So this applies probably to a lot of children who do survive out of infancy. Pulmonary valve, when it's too small, there's nothing that a surgeon can do to make it bigger. The living valve is the size that it is. And so our options are either to implant a donated valve from the heart of an infant who's died. We call that a homograft. Or more commonly, to just cut across the valve and sew in a patch that enlarges the outlet, but it doesn't leave the valve being functional, because there's no valve in the patch, obviously. Now, the difficulty with pulmonary valve in children with trisomy 18 is that so many of them develop high resistance in the lungs, and having a valve that doesn't close, having a valve that, or a pulmonary outlet that leaks, is a bad combination with high blood pressure in the lungs, because that causes a lot of back leakage and may not be tolerated. So I guess I would say I'll leave it to Dr. Kosiv to talk about cath lab options, but a surgical approach that assesses, well, first, assessment of the pulmonary pressures would be really important. And as a surgeon, my approach to a child who's beyond school age would typically be to try to implant a valve that would close properly and not leak.
Right. Thanks, Jim. Yeah, I think for the most part, we've been pretty lucky at being able to make a second, either a follow-up to either a conduit, like a homograph, like that Jim described, or even um, or when we sort of you lose the integrity of the valve because they've created a situation where in order to make it larger they had to cut across it and put a patch. But fortunately, in a lot of these situations we can actually replace the valve, or I would say put in a competent valve in the cath lab. So that's been really nice, sort of avoiding another operation. um, and so the reason why I think they probably mentioned, doing this at an older age, 13, is really because our goal would be to sort of put in a valve that is adult size, so, or at least a larger size. So, kids do a bunch of growing, we know that, we're not going to be the, the same size as we are when we're a baby, So the goal here is to try to put in the largest valve that we can, that then will have some longevity. So that's really the purpose. Now, the decision to kind of move forward with that procedure will depend on a couple things. So I'm sure that your child is being evaluated by a cardiologist probably pretty regularly, at least on a yearly basis. So the things that they would be monitoring are the function of the heart, especially the right heart. Um, an idea of just how large the right heart is because of all of that leakage, most likely. So as the valve leaks, the right heart will expand. And so there's a point at which, the heart is enlarging to a size that really, at this point, we're going to move forward with putting in a pulmonary valve replacement. And then there are other indications, for example, if there are any rhythm issues, obviously if there's any impact on, ability to do the activities that you might be doing. So, maybe that impacts kind of some sort of physical therapy or whatever the activities are. But if there's some concern for, what we call like activity intolerance, just the inability to kind of do the typical things that you've been doing, then, those are things that might move us in the direction of saying, okay, now it's time to move forward with replacing this valve. Um, so that's kind of the decision making. And then when it comes time to actually do this procedure, there's a lot of steps to sort of prepare for. Um, One, the placement or what type of valve we would place, what size, whether kind of getting ready for, the possibility there might be rhythm issues, or once you place that valve, it's kind of hard for certain doctors to get in there and address certain problems. So, for example, we customarily now do an EP assessment, so electrophysiology assessment, prior to sending patients to the cath lab. We also um, our interventional cardiologists, so those are the doctors that are actually putting in these valves in the cath lab. They usually get CAT scans or MRIs, both for deciding whether or not it's time to move forward, but also to see, okay, how does this area look? Is there enough space? How big? Just all of these kind of components that need to be necessary so that they can do the procedure safely, and then decide on kind of the size. And then the other kind of remarkable thing is the valves that we're placing now are probably not the valves that we're going to be placing in, 5, 10 years from now. So, even we were sort of limited size wise, in terms of the valves that we could place. And now we can actually there are larger valves that we can place, which, used to be sort of an indication to actually have surgical valve replacement, but now we can even put larger valves in. So this is like even expanding the possibilities of avoiding operations. Um, and um, and then in terms of the procedure itself, it's really neat. Interventional procedures are done without, having to enter the chest. And so we use these kind of like straw like catheters that look like kind of very long noodles. And then we're able to gain access to the heart through the vessels in the groin. And then usually you have at least two operators that are assisting to kind of get this catheter into the heart. And at the end of that catheter, there's actually a valve inside that catheter that then can be opened up. Um, there's a lot of important factors that come into this, things that would need discussion with an interventional cardiologist, the primary cardiologist, and then all the people that are assisting from radiology to the anesthesiologist, to kind of prepare for this. One other thing that Jim mentioned about this concept of high blood pressure in the lungs, I think is a really important consideration when preparing for any kind of major procedure. One of the things that might be necessary in terms of preparing is we call it diagnostic catheterization. So that's just where we're getting information about sort of pressures in each of the chambers and also sort of pressures in the lungs. Sometimes their medications may need to be adjusted to sort of help to make them help to make sure that the procedure goes well and that the outcomes after the procedure are successful.
Thank
If
you.
I could throw in another point and another question to you. When we enlarge the pulmonary opening with a patch, for example, the other thing that can happen is that the outlet just doesn't grow with the heart, and the child develops obstruction at that outlet over time. And maybe you could talk about what your approach to that would be in the case of a patch versus a
Mhm.
natural annulus, et cetera.
Yeah, I think there's just lots of things that we would want to know. So probably, so I'm thinking about it actually a case recently where I had maybe the opposite problem where, after placing the homograft, we had the sort of the hood of the conduit. So the hood is kind of like the area where it is attached to the heart before it's going out to the lungs actually grew significantly. So, though the patient had obstruction, and my whole hope was that we would be able to relieve that problem without an operation. At the time that when my patient went to the cath lab, and then they saw, oh wow, this is really we called an aneurysm or pseudoaneurysm. It's really not an aneurysm, but it's approaching that, I guess. Um, they realized, it couldn't be tackled w in the cath lab. It was not an appropriate step, and so we actually had to move forward with surgical revision. So that's where, as I would say, as the primary cardiologist, I think it's important to think about all the various modalities you need to prepare, for trying to get as much information as possible. So Jim, like, I think for that case where there's obstruction, getting an MRI to really visualize things maybe even before moving into the cath lab would have been extremely helpful. I think we have all of these things at our fingertips now. But let's say it was possible. Let's say my patient could have had that procedure. Our interventional cardiologists are pretty savvy. I'm sure at other sites too, um, using stents to dilate an area that might be narrow. Um, and yeah, they're like MacGyvers, in every respect. So I think that sometimes even though the less invasive approach sounds like it might be the right next step, it sometimes is not feasible or it isn't appropriate. I don't know if that was like a
Yeah. And also, sometimes despite their skill and all the tools they have, they just can't dilate the opening
Mhm.
adequately, uh, and that often happens in the case of a patch, unfortunately.
Yeah.
But and so it's not uncommon. It's uncommon, but it's not unheard of for a catheter attempt to not be successful or not adequately successful, and then to consider a surgical option if
Yeah.
that's appropriate. So,
Yeah. And there's all these dynamic components too. Sometimes we are examining things and it's sort of static, like we're just seeing one picture, but we have to understand that all the things that we're looking at are surrounded by vessels. There's a sternum, there may be scar tissue with adhesions, and so all of that is impacting sort of feasibility. So lots of variables can sometimes be challenging to predict and, can be why we say, really depends on what happens in the lab or in the operating room. But, that again, I think that's why it's important to do your due diligence, get as much information as you can, one anesthetic event, we try to combine things in terms of, when we put patients under anesthesia, oftentimes general anesthesia, though we can do a lot with sedation. So, um, maybe more than you wanted to know
Well,
about pulmonary valve replacement, but
no, that
this,
was really, no,
I think
that was
your message that that lots of information gathering is necessary
Hmm.
before the procedure. No surgeon or proceduralist wants to get a surprise in the middle of a procedure. We want to
Right.
know what
Yeah.
we're doing,
Yeah.
and then do it. So I think that's a great message.
Very comprehensive discussion. Thanks to both of you. Now, Mary had a second question, which we talked about. Rosie had her neck dislocate. She was in traction for a month and then had full repair with 2 plates on the back of the head, 2 rods, fusion, 5 screws, and bone grafting. She did fabulous! Exclamation point. I wanted to ask about atlantoaxial instability screenings, and if soft, she mentions me in particular, would recommend them as they do in the diagnosis of trisomy 21 Down syndrome. Rosie was misdiagnosed as acquired torticollis for months till an orthopedic surgeon saw her, ordered a CT scan, and saw that this C2 had dislocated and crumbled. So, as she points out, in Down syndrome, when screened, about 3 to 5% of children will have a dislocation of the first and second, the first vertebra moving forward over the second. That resulted in children with Down syndrome, as they entered, if they did enter Special Olympics when they would be 8 to 10, 11 years of age. Special Olympics, first time I heard that years ago, recommended screening of the neck in both a flexion and extensive position as it evolved. And while there's some controversy around that particular screening procedure, it is widely accepted and widely done. To my knowledge, and Marty, you could comment as well, I am not aware of that C1, C2 being collapsed or disrupted occurring in trisomy 18 like we know it occurs in Down syndrome. Now, we might not have looked. We don't know as much about older children with trisomy 18 as we know about someone with trisomy 21 Down syndrome, as we're discussing. We do know that vertebral defects all along the spine, from the cervix to the thorax to the chest to the lumbar and sacral region, can have birth defects of the vertebra, which may contribute to the common scoliosis of trisomy 18. But I'm not aware of that problem that occurs in Down syndrome being in 18. Marty, did you have a comment or anything to add?
Yeah, I think, you hit the nail on the head, John. I mean, with children with trisomy 18 or children with trisomy 13 or some of the other rare trisomies, we just know so little about their natural history that we're going to be finding things along the road here that we may not recognize initially as occurring generally within that population. The issue with Down syndrome is variably applied, but it is a Special Olympics requirement, as you mentioned, that everybody be screened with cervical spine films or other screenings to look for atlantoaxial instability. I know of nothing in the literature that Mary is referring to, but gosh, I think for us, it's something we need to put in the hopper and think about as potentially down the road. We need to be looking for this. I do not know of evidence that would allow us to stand and make a rec that we should go ahead and recommend that all children with trisomy 18, depending on what their activities might be, should be screened for this, though.
Yeah, as you probably know, some of the controversy was about doing that screening and it's being falsely positive. So I've read along the way, although I haven't kept up with it in recent years, that a good neurological exam might be better than actually doing the C1, C2. This again is in trisomy 21, but I think this is the type of structural change leading to a functional problem that we could imagine could occur in trisomy 18.
Yeah.
But we don't know now. So I think it is one of those things we should store and think about. We probably would need fewer kids than what it took to finally recommend that in Down syndrome. But thanks for the question. And Mary did go on to say thank you to all of us for what you do. I want to report that at 8 years of age, Rose is thriving developmentally. She seems to have just shot off. She tries to talk, walk, very social girl. I know I had worried things would only get harder for her, but despite the need for orthopedic surgery on neurogenic club feet and her neck, she is developmentally thriving and handled all these surgeries amazingly. So thank you, Mary, for the update, as well as asking 2 questions I think all of us have to have kind of there, not even on our back burners, our front burners, that maybe these problems with the cervical spine occur. I know in Wolf-Hirschhorn syndrome, which has a lot of overlap with trisomy 18, in Wolf-Hirschhorn syndrome, there are a few case reports we've learned recently of a similar cervical neck instability, making us wonder if that's another example. So,
If I could just interject
please,
on
Jim.
behalf of the whole group, I'd like to thank Rose's mother for what she's doing, because she and the other families that are raising these kids, they're doing all the hard work, and they're teaching us about this condition as we go along. So thank you.
Hey, Jim, I would add too, these parents, especially in particular Mary, Rose's mom, are also just staunch advocates for other families that are going through this. And they have their own daily challenges, to be sure, but they've been able to find the ability to give back to other families as well and to support them in their journeys.
Thank you, Marty.
Very true.
John, I would add, as far as the screening, I'm just looking up the current AAP recommendations for screening for Down syndrome. And you said this basically, but it's right on, is that it's not recommended that standardly we should be doing cervical spine films. They don't guarantee that the problem will not develop later, and there's a risk for false positives. So really, it does come down to a clinical diagnosis, at least as far as the AAP recommends right now. So I think for sure we should sort of hold on jumping onto recommending screening for other groups too right now.
But I think it raises that we need to have that list of indices of suspicion, and this maybe should be on our list. But
Which is difficult, right? If you're talking about things like headache, neck ache in children who have cognitive issues going on, maybe a little bit more difficult to make those diagnoses. But yes.
right. So thank you. So our second question came from Heidi. Hello, my child, I might mispronounce her name, Sahona, is 8 years old with trisomy 18. Should she still get blood work to check for alpha-fetoprotein? She uses abbreviation AFP. Do we always continue the blood work, and how accurate is it? So children with trisomy 18 are at risk for 2 tumors that are both related, actually. That is a tumor of the kidney called a Wilms tumor, and a tumor of the liver called an hepatoblastoma. Interestingly, these 2 tumors are referred to often as embryonal, which means that they probably arrived from predispositions during development. I mean, we wouldn't call them a birth defect, but in some way they're in a pathological category that's similar. Once we learned about that Wilms tumor occurred with a frequency of roughly 1% in children with trisomy 18, about 20 years ago, I started recommending periodic screening with a kidney ultrasound. That was for Wilms tumor. Then we learned about hepatoblastoma near the same time. We recommended doing the same ultrasound for both the liver and also include the kidney. But as more experts became involved and other conditions that also have an hepatoblastoma, the liver tumor and Wilms tumor, developed guidelines, we recommended that we do the alpha-fetoprotein, which is a marker, kind of like a polyp for colon cancer, a marker for hepatoblastoma. We recommended doing that every 3 months until 4 years of age, because really at 2 to 3 years of age, the risk for hepatoblastoma goes down to probably nothing. And therefore, 4 is a safe time. Certainly, we don't have to do it at 8. So the AFP could be stopped. That blood test is no longer necessary on a periodic basis. What we do recommend is that the kidney ultrasound, the renal ultrasound, be continued until 8 years of age because of that risk for Wilms tumor. Now, having said that, Dr. Braddock, who wanted to be on today but couldn't, and I have been talking to experts of Wilms tumor, and because we know of one child with Wilms tumor who was 10, we're going to increase the recommendation of doing the renal ultrasound, kidney ultrasound for Wilms tumor until 12 to try to be safe. But those have not been published yet. Dr. Braddock and I are still working on that. So to answer Heidi's original question, we no longer need to do that periodic blood test as a marker for hepatoblastoma. So thank you for that question because it brings up issue of tumor surveillance in trisomy 18.
John, did you mention how frequently that renal ultrasound should be done?
We do every 3 months following the same guidelines as for Beckwith-Wiedemann syndrome. And the people who are the experts on Beckwith-Wiedemann syndrome revised their guidelines. We're consulting them. So we're actually, as I said, going to change some of the guidelines for trisomy 18. If that answers your question. So thank you for that. So our third question is also a genetic related one, but I appreciate my colleagues all jumping in. But at least I'll make an attempt at the beginning. This is from Mary, from a different Mary. My question is regarding parent testing. So she's wondering whether she and perhaps the father of her children should be tested. I have birthed 5 children, 4 of the 5 having medical diagnoses as follows. A daughter, 2013, with DeGeorge, something Dr. Kosiv knows quite well, 22q deletion syndrome. That is a missing piece on the 22. Can't see with a regular chromosome study, require DNA techniques to diagnose it. Dr. DeGeorge from Philadelphia way back made the original observation. I don't see any relationship between that occurring and full trisomy 18. They would be incidental, as I'll go through the rest. It does turn out that about 10% of parents of children with 22q11 deletion syndrome, so-called DeGeorge, about 10% of parents carry a rearrangement that predisposes or have the arrangement themselves. So parents are usually screened for that deletion. Mary, if that's something that hasn't been done. My guess is that's been offered to you. The second child with full trisomy 18 was born in 2015, died at home at 1 week of age. There was no medical intervention. The third child, a daughter born a year later in 2016, has no problem. The next child, born in 2020, has agenesis of the corpus callosum, but has normal development. And we know that when you do incidental CT scans and MRIs, you will find absence of the corpus callosum, the little finger-like connection in both hemispheres of the brain, and that there are no neurologic complications. So her son must have had either an ultrasound or something that led to them finding that, but it's not uncommon to have agenesis with normal development. I can't relate that to the other conditions we're talking about. The next child with full trisomy 18, born in 2023, was born at 29 weeks and was stillborn. So Mary and her family did have 2 children with full trisomy 18, one living to a week and the second being stillborn. So her question is there a need for parents like myself to get tested when we have what we thought was an isolated diagnosis? We chose not to go down the path at that time of our last son's death, but my question hangs in the air. Good way to say it. Is it possible we could be carriers for trisomy 18? Is there research done on parent testing? Is there a possibility our children could pass on this gene? All great questions. If Mary was here, I would clarify what her age was in the birth of the 2 children, or of which her age is now. We could extrapolate. And I certainly would want to know, and she clearly says FT, full trisomy 18. So we must know that the chromosome study done in the daughter in 2015 and the son, who was stillborn in 2023, because she says full trisomy 18, I'm going to assume that they had 47 XX or XY with an extra full freestanding 18. That is full trisomy 18, as opposed to having most of or part of the 18 attached to another chromosome that could result from an unbalanced rearrangement, usually called a translocation. So in the next part of the discussion, I'm going to assume that both the daughter in 15 and the son in 23 have complete full trisomy 18. If that's the case, we do know that there have been families in the literature who have had 2 children with full, complete trisomy 18. Now, these are individual case reports of where a family had 2 siblings, and I have not known anyone in my own experience, but in SOFT, I did know a family who had a child with trisomy 18 and a child with trisomy 13, who are also reported in the medical literature. And in my own practice in Utah, I knew a family with trisomy 18 and trisomy 21, and there's also those in the literature. So these trisomies, basically 13, 18, and 21, that have a maternal age association and are the most common trisomies, have been reported to occur a second time in families, sometimes independent of even older maternal age. And as Marty knows well, we know that is the case in trisomy 21 Down syndrome. So we know in Down syndrome, if a family, even under 30 years of age, have a child with Down syndrome, they have a 1 to 2%, rather than a 1 in 1,000, whatever, 1 to 2% chance of having a second child. So what does all this mean? Well, there may be predisposing genes that have not yet been discovered in trisomy situations, particularly 13, 18, and 21, that's related to the way the chromosomes are supposed to separate in the formation of sperm and egg, and they don't. They don't separate. They don't disjoin. We call that non-disjunction. They don't disjoin. And there may be genes predisposing that explains the families who have had 2 children with trisomy 18, or a child with 18 and 21, or in the case of Down syndrome family, and I've known a few who've had 2 children with trisomy 21. So we don't know any of those genes. So there isn't a test for that predisposition that we have. So there's no carrier test for that. There may be in the future, because people are studying the genes that are important in separation of the chromosomes in that very early step, just before conception occurs, even after ovulation. So we may know them in the future, but we don't know them now. In another pregnancy, I would say, because of the 2 that Mary's family would be above the background risk, which is maternal age specific. One would have to know the maternal age to calculate that, but it would still be a percent risk. It wouldn't be a 10 or 15% risk. So that's how I would put this together. 22q11 is likely incidental. Amazingly, though, doesn't it seem that 2 children with trisomy 18 could be related to a predisposition? But if Mary was in her 30s at the time, it might be that the age-related factors, by the way, we don't know what they are either, might be the predominant issue. So finally, my last statement. All this assumes, which I think we can, that Mary's 2 children had full trisomy 18, because she was very clear about saying that, and that it was not a partial that could be related to a translocation. That this would be a lecture on meiosis at a master's level genetics course in less than 10 minutes. So I have no pictures, no slides, and that had to be complicated. But Mary, if after you hear this recording, if you want to email me, don't hesitate. I don't want to exclude my colleagues here. Anyone have any other comment or question for me that they wanted to make?
I have a question, and it might not be something worthwhile to include, but I want to ask it. S- because of this question about any relationship between, separate genetic conditions. I had a patient once with trisomy 21 and 22q11 deletion syndrome with tetralogy of Fallot Epsom pulmonary valve. Very, very challenging case. And, it was one of those like, how does how does that happen? And so I haven't thought about that for a really long time until this question came up in terms of if there's a possibility that um, there's something else in the background that is causing.
Hey, so what we could hypothesize, Katya, all these chromosomes. I went to a conference last week in New York, in Stony Brook. 70 years of 46 chromosomes. I mean, Theo and Levon's paper was in 1956. So now we have 70 years. And it was actually a really interesting discussion. And I heard a brief talk, I wish it was more, on some of the basics of chromosome biology. These, we think of them as blobs. When we see them in a karyotype, of course, it's a metaphase spread, artificial, real, but artificial in that sense. That's only something that occurs a few minutes in the life of chromosomes. They're all, so it may be that these chromosome interactions, that a deletion, that we think that the 22q occurs because there's a misalignment of the two 22s being together, and they rearrange incorrectly. You end up with the deletion, or in the opposite case, a duplication. So this kind of thing might be interacting, not long before a non-disjunctional event could occur, and that the two could occur together. And the only thing, Katya, I can say right now that argues for that maybe being the case, and Marty may have read this in his many readings of Down syndrome. This has, I don't know that this has been studied for a while, but children with Down syndrome have an increased occurrence of unrelated balanced translocations that may be familial, may be de novo. So some people have predisposed that having a balanced translocation of non-21 could predispose to non-disjunction. So that has been hypothesized. So we could imagine, you say, oh, this is a coincidence. So when I said, in your family, in your child that you saw. So when I said to Mary, this was it could be that the 22, that whatever the predisposition to non-disjunction could have had some role in the 22q, but I don't know. I can't prove it.
And I recently met another family who has a living child with trisomy 18 and is currently going to have another child with trisomy 18.
Right. So we know that where Down syndrome has been studied so much more thoroughly, we know that the only explanation for why a younger family, if we take out the maternal age factor, whatever those are, issue, we say a family who's 23 and then 3 years later have a second child with trisomy 21, pure trisomy 21, other than one of the parents being an undetected mosaicism for trisomy 21, which one can look for, but we don't tend to do that routinely. The best explanation for that is that there is some genetic predisposition and non-disjunction. But I suspect we will know about that given the recent work in genomic medicine.
Can you also have a situation where, you have a child with the initially trisomy 18 mosaicism and then a subsequent child with full trisomy 18, because I've seen that as well.
So you could, in this way, people think that mosaicism occurs after conception and the non-dysfunctional event occurs after a few cell divisions. But we know that there are proven situations where there's trisomy 21 at conception. They prove the DNA. They call it trisomy rescue. And the extra 21 is lost in cell division. So the person with mosaicism ends up with a cell line of 46 and then 47 plus. So you can imagine that the child with mosaicism started as full 21, but then there was the so-called rescue, and they're under the same umbrella of predisposition. But again, I say maternal age factors, and I have no idea what I'm talking about. All this could be related to whatever these maternal age factors are. There has been, have to go back now, well, really in the 30s it started. We didn't know how many chromosomes there were. So there's been almost a century of thinking about non-disjunction. They do occur in fruit fly. So been a century of thinking about this, PhDs galore. And that part is still a mystery.
John, can I ask a kind of a simplistic question? Just being a surgeon and everything, but if there's an occurrence twice in one family or one pairing of a mother and a father, wouldn't that imply that likely both parents, if they're both unaffected, would have contributed such a gene, i.e. a recessive trait? Or is that just
not a naive,
too simplistic to even answer?
No, it's not even a naive question. It's actually an excellent question. I mean, when the non-disjunctional event occurred, if it occurs preconceptually, occurred either in the mother's oogenesis, descendants, or the father's spermatogenesis descendants. So ordinarily I would think that the predisposing genes would have occurred one parent versus the other. Now, if a family, as Katya knows, if we take trisomy 18, or having two children, DNA studies could tell you which parent the extra chromosome arose from. And you could collect parents that have had trisomy 21 would be easier to study. And you could determine that in every case, it was the father where the non-disjunctional event occurred as opposed to the mother, or vice versa. And maybe, and I don't know this ever been studied, when there are two children, to find the parent of origin. I don't recall ever saying that that's been done. So to me, your question, throws up the idea of more studies in that area. But I don't keep up enough with that early literature. I know from Marty's recent paper he told me about at Christmas time, I know he looks at some of this cell biology, but there used to be a guy named Terry Hostel was moved to Washington State a few years ago. He was like the world's expert on non-disjunction, but he's retired. So I don't know if there's someone else around on that that could answer that question better than I.
Hey, John, we talk about full trisomy and mosaic trisomy, and it is not uncommon that we'll get, a family that thought their child was a full trisomy, and they get something other than the blood tested down the road, and they realize, well, no, you weren't a full trisomy, actually. I mean, what are your thoughts on our ability to designate someone as a full trisomy versus a mosaic?
How much time do we have, Nick? Anyway, it's a question about
Yes.
mosaic.
I'll keep watch, John.
Like in general, like mosaicism. Like we talked about this in the soft community all the time, because we knew that if a child with so-called full trisomy turned out on a repeat study that maybe looked at another tissue, to have mosaic. In Jim's cardiac surgery world, Katya's too, there was a more openness to operating on someone who had trisomy 18 mosaicism. They didn't think they had the prognosis of decreased lifespan and so on. But in some ways, we probably should be, and this is the way Jim approached it, we should be approaching these kids regardless of which one of those chromosome diagnoses they have. But when we do a chromosome study at birth, and someone looks like they have, or prenatally, looks like they have Edwards syndrome, we do it, we count 20 cells, we say they're full complete trisomy 18. And we don't do anything further. We make decisions. We don't say, oh, before we're going to go to the next step, let's do a few more studies. We don't do that. And so almost everyone is an assumed full complete trisomy. And we know those examples that you just said. And some people have proposed that all babies, live born babies with trisomy 18 and 13 has been thrown around, probably have some mosaicism we haven't found. And again, that's why I asked Nick how much time we had, because I'll make one more and then I'll close the discussion. Ken Kupke was a neonatologist at Boston Children's and Harvard back in the 80s, and he did a parent of origin study, came to a soft meeting and collected 20 families. Some of those 20 families are probably watching this recording right now. What he said was, in the discussion of the paper, and he was able to say, by the way, that 19 extra chromosome came from no one's responsibility, no one's fault, but the original origin was on the maternal side, one was on the paternal side, so 19 of 20. But he said that when he looked at the what they called southern blots, and they're looking for these bars that come from the DNA, when he looked, when there were 3 bars, again, I'm not the right person, but when there were 3 bars, most of the time, one of the bars was fainter than the other 2, suggesting that there was less DNA, suggesting that there might be more mosaicism than we think.
John, can I ask, I know you wanted to wrap that question, but can I ask you something? One of the ideas that we had in Nebraska when we were operating, generally, when you do heart surgery on a baby, a gland called the thymus, which is right behind the breastbone, is in the way of getting access to the heart and the blood vessels. And so it's very commonly removed at the beginning of a cardiac operation. And so my question was, we had this idea that we should have that thymic tissue assessed for mosaicism. And I think we tried that, and I don't know how many patients there were, and I don't think we found any mosaicism. But given that that gland, that organ, has origins from multiple parts of the embryo, do you think that would be a worthwhile thing to look at?
Well, I think it'd be worthwhile because we have the convenience of adding the tissue, not to do any other kind of tissue sample. I'd have to ask an immunology colleague, like you said, there's a population of cells, but it would be a convenient way if someone would say, okay, I'm willing to do those karyotypes on next 50 surgeries to see how often in trisomy 18 and trisomy 13 we have undetected mosaicism in a child who's probably young and who's getting surgery. We had talked about, Katya knows, in this study, and we're going to go back to the Patient-Centered Outcomes Research Institute for one more try, see if we can get Marty knows about it too. The natural history study done, also other elements to the study. And there's a number of soft families that are on the parent advisory board. We had talked about trying to do an ancillary study like you just said, Jim. We didn't think of thymus at certain time of surgery, but we thought about collecting cheek swabs. We didn't put that in the grant because we thought it may make it too complicated, but we do have this potential captive population of over 200 children with trisomy 18 and 13 combined that we would be actually seeing over the course of 2 years. Anyway, potential ancillary study.
Thank you.
It'd be harder to do it to use cardiac surgery because, as you know, in the Greenberg study from the Phys came out about 2 years ago, Journal of Pediatrics. At that point, and Jim, you've talked about this many times, and if I recall, in their study, only 18% of the children with congenital heart malformations, 13 and 18, had cardiac surgery. Now we know that number is going to increase. In Katya's study, I recall it was 7%. So those in a study like this, the Cincinnati study, it was one of 2 of 72 or something. In the we know that the number actually getting surgery will be a smaller denominator. Anyway.
And you're right, that number is rising. When I looked at this the first time based on demographic information, it was 6% and then 7%. And so, I mean, if it's 18%, that's a big increase.
Well, in some of the hospitals in Japan who are doing intensive intervention more, not all of them are, more regularly, and also cardiac surgery, 50% of, the latest study by Tamaki, 50% were having cardiac surgery. 50% of children with trisomy 18.
I wanted to ask one more question along the same lines, which is prenatally done cell-free DNA testing. Does the intermediacy of results, does that have any relevancy for mosaicism?
That's also a good question. I think if there was when you get a positive result, they don't say trisomy 21, they say positive result for trisomy 21, meaning that the amount of DNA was consistent with trisomy 20 or trisomy 18. I think I don't think they can distinguish from that DNA measurement a mosaicism. You'd have to wait for the amniocentesis, which the role is recommended to have so the cell-free DNA is a screening test. If it's positive, American College of OBGYN, American College of Medical Genetics recommends having an amnio at 15 weeks. There you could look for mosaicism. But I don't think you could look for it in the cell-free.
Yeah, I agree, John, just like in my prenatal world. The other thing that I think is just on this topic is like the number of cells to count. And if there is some sort of threshold for defining mosaicism versus full, or where the tissue is sampled, and
when they count the 20 cells is the standard now. I'm not a certified cytogeneticist, so I can't say how predominant that is in practice. But from what I understand over the years, if you count 20 cells, you've excluded 10% mosaicism or more with 90% certainty. That's 90% in one statement. Again, I'm not a biostatistician, I'm not a cytogeneticist, but you don't exclude it 100%. And you certainly don't exclude, let's say, mosaicism of a degree or of 20, 30%. So it's a probability, it's a statistical choice of standard of care. But we base a lot of our early decisions, 3 and 4 and 5 week olds and whatever, on one, that it's complete. Now, maybe if we're going to not use that to have anything to do with decision making, but use the baby's heart and other issues, might not make any difference.
Yeah, and I don't know if it would be helpful, but like cell-free fetal DNA, John, this is my spiel that I give patients. It's really placental DNA that is found in mom's bloodstream, which is thought to be identical to the fetus, but not necessarily. There could be mosaicism within the placenta. And so when each of those companies that administers or that, the test will also provide like the positive predictive value and the negative predictive value of that specific syndrome or gene, you know what I mean? So it's so our go-to, unless there's like ultrasound findings or other things that really make it hard to, disagree with a finding, will always, even in those cases, they'll say, really do recommend confirmatory testing with an amniocentesis or a CVS early in the pregnancy or postnatal confirmatory testing.
It's a good skill to have because the positive predictive value, it has gone up in the labs that have been like the Terra that have been doing it for a while. In Down syndrome now, I believe it's 98, 99%. But in trisomy 18, it varies in the labs from 70 to 80%. In 13, it's only 50%. This is positive predictive value. And in Turner syndrome, 45X, it's less than 50%.
And it depends
Yeah,
on
and
maternal age.
It does.
I've had tests come back, confirmatory tests come back negative.
It also depends on the frequency with which any of those diseases or abnormalities occurs. If something is rarer, like trisomy 18, then a positive test doesn't mean as much.
Right, and that goes along with what Marty said in the sense of the age is also predictive of the frequency at that particular age. So, and though again, I couldn't do the statistics, but those are factored in.
Yeah, I think what Katya emphasizes, the positive predictive value. That's what you want to know. That's what you want, Jim, because it factors in the incidence of the disease, and it's really variable with age. We all know this. I mean, an 18-year-old versus a 45-year-old for risk for any of these is very, very different. But that distinction is often not made very clear to people undergoing these tests. Quite honestly, it's often not told very clearly to moms who want to find out the sex of their baby, what else they're going to be looking for when they have these tests.
You are definitely right about that, Marty. So we should move along. Nick, I think we're fulfilling your request to have rich discussions about every question.
Yes.
We do have Linda's question, which is complicated and has multiple facets to it, and it's an important question. So Linda asks, what is known about which anesthesia can safely be used with a trisomy 18 child? So anesthesia, that's part of her question. And Jim and Glenn in particular, all of us might address that question just about anesthesia in trisomy 18. But then she goes on, what is known about unstable blood sugars in these children? Our nearly 5-month-old baby Laura died after being put under anesthesia for a routine CT scan. And a lot of times in young children, they will sedate with general anesthesia, during which her blood sugar dropped to less than 10 right after being put to sleep. So she got rapid hypoglycemia, and she quickly spiraled backwards. They brought her back to the floor where they struggled with her first to start fluids, give antibiotics, and get her blood sugars up, stabilize her breathing, etc. But she kept going backwards until she coded 5 hours later. So anesthesia for CT, blood sugar dropped, severe hypoglycemia. They did CPR for 25 minutes till her heart rate came up, but she died 2 days after. An MRI showed her brain was damaged with massive swelling. So cerebral edema from perhaps the asphyxia, etc. She only received breast milk for her nutrition up to that night, but this time they chose to run a Pedialyte through her G tube several hours before switching to NPO, which I believe also affected her. A blood gas from early morning showed a moderately high blood sugar, but it wasn't read till after she was back in her room, now in shock hours later. She often ran borderline blood sugars, but never where she was sick as a result. She was in NPO for about 5 hours without any IV fluid prior to the procedure. Also an error on their part. So she was dehydrated by the time as well. She had anesthesia numerous times before and did fine, but never had the particular kind they used this time when she had her CT. I saw the precautions when I Googled it. It's not to be used with diabetics as it affects the blood sugar. So I don't know that we know what that anesthesia was. I don't remember the name of the drug, though, because that information was withdrawn from the medical file soon after her death, and I didn't write it down. The doctors believe she was septic, but found no infection. That's why, of course, why they were doing that workup when they brought her back. I believe it was the anesthesia that pulled her down and not an infection. She was very hungry before going down for the procedure, but not acting sick. She was awake and interacting with her daddy the whole time, begging for milk. She was a marvel to us all, very communicative, interacted very well. I believe she would have gone far if allowed to live. I would wish this subject could be studied and widely published, especially to children's hospitals, as they work with many of the trisomy babies, so other babies can be spared. I realize she was quite medically fragile, so something like this can change things fast. So this is a multifaceted, a complicated situation. Certainly there is the question of anesthesia. I don't know what the anesthetic was that was going to be used at the time.
I could interject real quickly on that. ChatGPT says that it's halothane, and it causes increased insulin secretion, especially in infants.
So the ChatGPT said that in this situation, that would be the most likely anesthetic given for something like a CT scan procedure?
No. I only asked it which anesthetic drug causes hypoglycemia.
I gotcha. Thank you. That was the better question to ask. Okay. Right. So maybe even though she didn't recall anesthesia, statistically at least, that given the hypoglycemia that she had, because before that she had in some blood instability and hyperglycemia, but here she had severe hypoglycemia, and so halothane would be the most likely answer as far as the anesthetic.
Yeah, and again, that's just what ChatGPT says. That's not from my knowledge bank. So confirm if it's important.
Right, and she admitted that she didn't know what that anesthesia was when she was thinking. So Glenn or Marty, did you have any experience with halothane and hypoglycemia?
So just to make a comment on anesthesia in trisomy 18, because that's something that we've published on, and it is not to be taken lightly. So no kid with trisomy 18 should get an anesthetic in a dental office or in a surgery center or at a hospital that's not a children's hospital or an outpatient facility. Airway problems are significant. About half of kids will have significant airway problems that are noted that can cause problems, including hypoxia, and you give anesthesia on top of somebody that is already has borderline airway problems, and it can make things substantially worse and really put the kid at risk for this kind of spiral of multiple systems going down and going bad. In our group, I think we had 10% ended up with bradycardia and hypoxia getting anesthetics. That's with an otolaryngologist around an experienced pediatric anesthesiologist. And this especially applies to neonates with trisomy 18 as opposed to older kids. And so this was a person that was at very high risk for having troubles with anesthetic. They were young, presumably had some degree of airway obstruction that wasn't fully evaluated beforehand. Then you have a lot of troubles afterward. And seeing hypoglycemia in a component in somebody that's arrested and had all these other problems is not totally surprising to me. And the agent per se would influence that, but the whole context of a kid with trisomy 18 is part of this here. And so that the thing for everyone to take out of this is to not treat any anesthetic as benign and uneventful. You want to have really good people around for any child with trisomy 18 getting an anesthetic.
Thank you, Glenn.
Hey, John, How old was this child?
5 months, I believe, Marty, but
Months. So
let me
typically for a head
verify that.
CT,
Yeah, she was
no
5
one would
months
be
old.
probably not using gas at all. It would probably either be a benzo and a fentanyl or an opioid, or maybe propofol, but none of those are associated with hypoglycemia per se. What I would worry about is the baby's going down for seizure eval. Does the baby's pituitary work? Was the kid stressed? I mean, is he adrenally insufficient? Was that evaluated? So maybe this could have been just a stress response related to a CNS abnormality, possibly.
Right. The other thing was when I said quickly CT anesthesia at our children's hospital for CTs as opposed to MRIs, even in young infants, we don't sedate them anymore.
Correct. Correct.
I don't know. Well, I can't say there aren't exceptions to that. I'm not a radiologist. I'm ordering CT scans at this point,
Yeah.
but I'm surprised in retrospect. MRIs, yes, but CTs, I'm
Yeah.
surprised there was any
We
sedation.
always will try and send them down without sedation. I mean, a baby 5 months for sure. But there are the kids you send them down, and the motion artifact is so horrible that they come back. You can't even read the scan, so you end up sending them back down, and you might use sedation at that point. But yeah, you're right.
Uh,
I mean, you would probably just wrap the baby up, feed him before he goes, and be done with it. Hopefully,
yeah, feed and swaddle because it's so fast, you know. Also,
So
like I mean, we do feed and swallows for cardiac where we have a movement. This was for a brain, so I mean, less movement. I would think that. I mean, apart from I guess turning your head, but you could put so.
So sometimes short of anesthesia, sedation is given, as Marty was talking about, I think. And I guess I'd ask Glenn for his thoughts about the wisdom of a conscious sedation with a patient in the scanner in a child or an infant with trisomy 18. Uh, I think that they're particularly susceptible to difficulties, and I think that an experienced anesthesiologist in a children's hospital would favor general anesthesia or nothing.
or at least very close monitoring while something's given. So you need to be very cautious in giving sedation to any kid with trisomy 18.
yeah, I think that's maybe one of the most important messages of this part of the discussion. I mean, that should be put in bold in even health supervision guidelines in just the way you articulated it. So that's one issue of the anesthesia. The fact that halothane causes hypoglycemia might have been a factor that precipitating we don't know that it was halothane, was the spiral. But there are a lot of issues packed in her story. Any other comments or wisdom we can add
Yeah,
for the
John,
family?
as a side comment about anesthesia, what I often encounter with families in many places who they would like to have things done with their kids is that at surgical interventions, whatever it may be, well, to put your baby under anesthesia is really a life-threatening thing. And your baby may not survive. I mean, I hear that all the time being told to parents. And I think while we're saying clearly that you need to be cautious and these babies are a little bit higher risk, with the right people in the room doing the right things, it's not a death defying experience. And I've even had parents told, even for a G tube or really minor procedures, that, anesthesia. Oh, you don't think you want to do that? You should probably just go home and not consider this procedure.
Marty, thank you. That's a really important balance to the other part of the discussion we had. So thank you for that. And I think the message is, of course, the right people in the right place. And I mean, I know I heard that about cardiac surgery, Jim, back in the 80s. I mean, not necessarily at our institution, but even going to soft meetings and hearing that from parents, why, there were only until the 90s, 2000s, there were nothing but case reports about cardiac surgery in trisomy 18 and trisomy 13.
Does anyone here have a desire to have a closing word or a synopsis of any kind? This is not out of obligation. This is just out of curiosity, because I won't see you guys for a little while.
This isn't a synopsis, but John, there was a first question in that last question, that last case, wasn't there? Sort of a first question and then the question about
Well, the
anesthetic?
first question was anesthesia in these kids.
Huh.
And I think Glenn and then Marty's perspective about right place, right time. We shouldn't not do anesthesia when it's needed. But her first question was, in fact,
I thought she had
what
another
is known
question.
about anesthesia can safely be used in trisomy 18.
Okay.
I think we
All right.
answered that.
There's one thing that I want to make sure. I'm getting called to the OR, and I've got problems. But I want to say one thing. One is with the concern about atlanto-occipital instability or dislocations. Those kids we worry about that a lot in otolaryngology because we're extending the neck. The kids look like they have their head twisted to one side, and so a torticollis would be a common way that it would be misdiagnosed as torticollis. And if you've got a kid with trisomy 18 that has their head twisted to one side, that shouldn't be ignored. You should get films to look at that, both because it can represent something like that, cervical anomalies or weak tone or other things that would be worthy of intervention. And then, John, I want to ask one more thing. And how early do you get your first AFP on trisomy 18?
We start in infancy, early infancy. We start in the we get a baseline. We get a baseline in a child that's going to leave the nursery, because their AFPs tend to be higher just because of pregnancy, and maybe even higher than you. So we start when they're going to go home.
Just to tag on to what Dr. Green was saying, to expand a bit, any baby and any child really who's having anesthesia, deep anesthesia, where they're going to have a breathing tube put down into their trachea, has their head extended quite a bit. That his warning and his advice really applies to any anesthesia.
Yeah.
Thank you.
Yeah. We had a case where kind of came out of nowhere, that was discovered, and it was a huge decision about moving forward with cardiac surgery because of that, because of the hyperextension. And then actually for this patient was the risk for injury to the spinal cord. So, which may be like totally different, but I think it's about the same for atlantoaxial instability.
I just made a note of that to not forget that. But
Yeah,
what we're talking about now,
because we were like, well, we don't want to try to solve one problem and then create a huge problem.
Yeah.
So,
but at the same time, it would be an important message that none of these things prohibits a safe anesthesia. Obviously, Rose went to sleep to get her neck fixed. You can intubate with a fiber optic scope. You can do things, and it can be done safely. So it's just a matter, as you guys were saying, of having the right people in the right place.
and like Mary mentioned, that Rose did have torticollis which they diagnosed it for, and in fact, it was the instability related to the second cervical vertebra. But
so, we didn't get to that last case, y'all, but hydronitis, atlantoaxial instability. I mean, these are all things that we just don't understand in these kids, and we're going to find more stuff like this as there's more kids surviving. And hydronitis is really interesting, John. I didn't know much about it until you guys threw the case out, and I started reading about it yesterday and today. Maybe 2 to 3% of people with Down syndrome have it. It's a really severe condition, which I did not realize. and is very debilitating. And so the genetic mechanisms, there's multiple genetic loci that have been isolated related to this condition, and across numerous chromosomes. So I think we're going to find more and more stuff as more and more of these kids survive. And, I think we're an important conduit for people bringing these symptoms and clinical presentations forward, so that we can sort of describe what the phenotype is like down the road for these children.
Absolutely. If you're one doctor with one patient with trisomy 18 and the child has, this atlantoaxial instability, you don't learn anything. You don't learn anything until you put all these people and all these children together, and then you start to see patterns like the bone fragility, John, that we noticed in our cardiac patients. We wouldn't have known that if we didn't have 20 or 30 of them,
And John, I wonder if in our grant proposal, this kind of thing should somehow be worked in there, that, this work could serve at least in some way, shape, or form as the beginning of a repository for sort of, you know, understanding what the phenotypic timeline is for people with the different trisomy conditions, 13 and 18.
And as we wrap up this special episode for Trisomy Awareness Month, I want to take a moment to recognize a few people. Thank you, Dr. Kosiv, Dr. Hamill, Dr. Green, and Dr. McCaffrey. Thank you for sharing the time, expertise, and just leaning into this conversation with such thoughtfulness and care. And to my co-host, Dr. Carey, thank you for helping guide this discussion and for your continued leadership and dedication to the trisomy community. This panel's been an honor to be a part of, and I'm just so grateful that they could share such wonderful message. Our hope is to continue conversations like this throughout the year, and we're especially looking forward to this panel and a few others joining us at the SOFT conference. And those of you watching, thank you for being here. If this conversation was meaningful to you, we'd love for you to share it, leave a comment, or pass it along. We want more families to hear the good news from these doctors. These conversations matter, and we're grateful you are part of it.